All right, hello and welcome everyone to the Friday update with Mendocino County Public Health. My name is Cameron Brown, and as always, we're very happy to have our County Health Officer, Dr. Andy Coren, with us today. For the schedule, we'll get the COVID-19 updates for the county from Dr. Coren. Then I will actually walk through our new dashboard on the website. Then we'll jump in and take in some questions from local media. And then, as always, we'll check on Facebook and YouTube for questions from the public as well. So we'll jump right in, and I'll hand things over to you, Dr. Coren.
Thank you, Cameron. So today I'm going to briefly review the data for Mendocino County, the United States, in a world of COVID, now in the days of BA2. And also we'll then have that presentation on our new dashboard by Cameron. So the daily new cases now are down very nicely. Mendocino dashboard currently shows 3.88 cases per 100,000 per day. Now, there are some discrepancies. If you look on the state dashboard, it shows 4.4. CDC transmission rate shows 6.7. The important thing is that in all of these dashboards, which count things a little bit differently, the risk is moderate. Our community level, that's the transmission risk, is moderate. Community level is actually low, and that, of course, is based not only on the case rate, but the hospitalization rate and utilization by COVID patients. Our testing positivity is down to 2.8%, and in California, it's 1.3%. But again, PCR testing has decreased to less than 200 per day, and that's the lowest since before Delta. So the reliability of these numbers is less than it was, let's say, 2 or 3 months ago. Note, though, that those testing sites and traveling teams in the county that have been run by OptumServe are now performing both PCR and rapid antigen tests. Hospitalizations are now down to one Mendocino County resident who's actually hospitalized in a hospital out of county, and we have no COVID patients as of last night in any local hospitals. So our bed availability is not stressed from COVID. This means, as I said, that the CDC community level risk for hospitals is low. However, we have lost another man to COVID. This was an 82-year-old Hispanic man from the North County, and he was not vaccinated. Vaccines are still the most effective way to avoid hospitalization, intensive care, ventilators, and death. Adults with 3 doses of mRNA vaccine were 94% less likely to be put on a ventilator or die from COVID. So while vaccination rates are slowing everywhere, we're still seeing some demand by people who may not have been able or willing to get vaccines before. In the last month, 1,566 vaccines were administered in Mendocino County. In Mendocino County, as of March 29th, based on the state and federal data, 73.3% of eligible people were fully vaccinated. 89% of people over 65 years old were fully vaccinated. 54% of eligible people were boosted, and 74% of people over 65 were boosted. New FDA and CDC has given emergency authorization for second boosters, and these would be administered 4 months after the first booster for anyone who's over 50 years old, for people who are immune compromised, people who are over 12 years old are eligible for Pfizer, and for people over 18 years old are eligible also for Moderna. And those who've had initial and booster vaccines that were made by Janssen are eligible for another booster, and that could be Janssen or mRNA. Applications for emergency use authorization are pending now for people 0 to 6 years old for Moderna and Pfizer primary series, and we're still looking for an authorization for boosters for people 5 to 11 years old. You may have noted that federal funding for the uninsured testing, vaccination, and treatments has ended, and this could cause some significant disparities and a rise in cases, but CDPH, the California Department of Public Health, will be covering those uninsured people. However, it is recommended that they register at a clinic or another Medi-Cal provider that can sign them up. Current recommendations with a moderate substantial transmission risk for individuals, and because we're in low community levels, for individuals, we do recommend indoor masking, strongly recommended in public indoor settings. High-risk individuals and their families may want to wear a mask with a higher grade protection, and some who live with very vulnerable people may even want to wear a mask at home in those situations. We do recommend, if there are any new COVID symptoms, that people test and stay home. And also, of course, to stay up to date with vaccines and boosters. Within organizations and governments, it's important to maintain the testing, vaccine, and supplies that we have, and work at this time on indoor ventilation. Universal indoor masking is still required for hospitals, nursing homes, outpatient healthcare facilities, corrections, congregate care settings and shelters, and public transportation based on federal law. And there's more than just masking for travel. Isolation and quarantine after those 5-day early release, people are still required to wear the masks for the full 10 days. So I'm going to move on to variants now. We know that COVID will continue to mutate, and the rising variant now is called BA2. We're seeing recombinant viruses as well, that is some BA1 genetic material combined with BA2 genetic material in the same virus, some Delta crossed with BA1, but these so far seem to be petering out where they have been detected. If we can go to the first slide, that would be helpful. We look for viruses that have a growth advantage, and that I think we see here. You can see the rise of BA2 on the left graph, and this is as of March 26th. And you can see that the modeling team has extended that pink line to expect 70% of BA2 in California as of March 30th, but we expect it to be almost 100% within the next week or so. On the right, you can see how rapidly the pink bars, which are BA2, have sort of pushed out the BA1 in our state. And so this is showing that growth advantage. We know that it is about 30 to 50% more transmissible than the BA1, which is very, very contagious. And it is now the dominant, as I said, dominant in California, and we have detected it in Mendocino County. What we now know is that it does not appear to escape immunity from vaccines, especially for people with boosters or of prior infections. These are highly protective against severe disease, hospitalization, and death. It does not appear to be more virulent, as we do not see an increase in hospitalizations or deaths where BA2 is predominant or on the rise. The BA2 does have more resistance to one of our outpatient treatments, sotrovimab, so we're not using that now in California. And we have been learning from this that monoclonal antibodies are of temporary use. As new variants emerge, apparently it's much easier for them to escape the immunity from monoclonal antibodies. But we do have other alternatives to use. If we go to the next slide, internationally, we've been reading about rises in BA2, and we've learned a lot from that. This set of graphs show in various different countries in Europe and in the Far East that the proportion of BA2 is rising, but the case rates in many cases are decreasing. So the proportion of BA2 is in the gray lines, and the prevalence of infection is in the colored lines. And you can see even in those areas where it has where it's increased quite a bit in proportion, the overall numbers of COVID have decreased, which is very reassuring. Variations between countries are due to many factors. In some cases, where BA2 is responsible, we think mostly in Europe and Israel, there seems to be an overlap of BA1 and BA2 in some of the Asian countries. But the variations seem to be related to many factors such as the age of the populations, their vaccination rates, differences in the vaccinations that they have had available, and waning immunity. Other important considerations that we think are probably even more important are differences in mitigation practices. For example, China's had a zero tolerance policy. And probably most important has been the timing and speed of relaxing important controls such as masking. In California, we believe that the careful, gradual, evidence-based relaxation of our non-pharmacologic interventions, social distancing, masking, duration of isolation and quarantine, to name a few, will prove to avoid these terrible rebound surges. Nevertheless, next slide, please. A new wave is expected in California in May. It is expected to be less of a surge and more of a wave, probably not significantly affecting rural Northern California region hospitalization or ICU rates by the current predictions. However, we still must be prepared for other variants to emerge. As far as treatments, we now have a good supply in Mendocino of effective treatments, oral or injectable, for people with mild to moderate COVID. So I encourage people, especially at higher risk, to call your providers early with your symptoms to test and start the treatment within 5 to 7 days when it is most effective. Also, people who may be at increased risk from, for example, cancer chemotherapy or other immune compromising conditions or medications may be eligible for very effective pre-exposure preventive medicine that can last as long as 6 months. And these people should call their specialists for advice and for their treatment. So with this break in surge, Mendocino Department of Public Health is making some exciting changes. And one of the first ones is the change in our dashboard. And I'm going to turn this over to Cameron Brown, our man behind the scenes and the moderator for our conversations, to discuss our newly upgraded dashboard. Cameron?
Thanks, Dr. Coren. Let me just get the screen share going. All right, so just to orient everybody from the home page, here we are in the County of Mendocino. That orange bar at the top, where it was easy to get to the COVID pages, has now disappeared. So now we go through this community icon, and then here's the main COVID pages. So let's start on the main one for now. And then for those that have been following the data on the website, that's been living here at COVID case data. But starting on Monday, these old graphs we've been using, which have had cases by region, cases by zip code, and then this is our old dashboard. This will all disappear on Monday and be replaced by this new dashboard, which we'll go through today. So this one actually has a lot more data, and it's broken up into 4 categories. And it'll look a little nicer than this when we publish it. The first is vaccination coverage. And then, of course, we describe the data updated twice a month from CDPH. And the first graph, also all graphs are in English and Spanish. This first one is an overall look at vaccinations in the county. And you can see about 70% of the population has been fully vaccinated or fully vaccinated with a booster. Here's our partially vaccinated at 9% and then unvaccinated at 18%. So here's the overall look. If you want the fine details, here's our data source and the current date it's from. And then a little more detail about vaccinations. This looks at age group. We see the 65 and older neighbors and residents in Mendocino are the most vaccinated at 90%. And it just kind of goes down the gradient here with ages. And then same thing broken up this time by race and ethnicity. And you can see there are a lot of differences based on race and ethnicity with vaccinations. So, and again, the details on the data, this is current as of the 10th. So Yeah, here's our vaccination page. We'll move on to the second one, which is hospitalizations. This is a different type of table. This is actually straight from the state website, and we've just embedded it here. Let me zoom out for a little bit better view. So this looks at hospitalizations. There's a lot to take in here. Starting on the left is just the raw numbers of positive patients. And you can see Mendocino, oops, it's down here at 0, thankfully. And here's kind of the number of positive patients in the hospital and the ICU over time. So you can see our Delta spike there, the Omicron spike here, and then back here at 0. And this map is blank now, but if there were hospitalized patients, it would show which parts of the county, if it was Coast or Willits or Ukiah. So this is and also ICU availability beds, another important metric to follow. So this is our hospital page. Because this table is so wide, it cuts off our sidebar. So you have to kind of maneuver your way back up here. Next category is looking at cases and deaths. Again, we've already looked at vaccinations and hospitalizations. So now we're just looking at raw case numbers and death numbers. Starting on the left, this is the case rate. It's not the actual number, but it allows us to compare a smaller county like Mendocino with a bigger one like LA or San Francisco. And we can kind of compare how COVID's spreading in different counties. So we're kind of down here in the middle with 5 cases per 100,000. And again, you can follow it over time. You can see the different spikes. There's Omicron in January. And then we also have our total deaths here. And also deaths over time. So you can see some of the spikes associated with Delta, and then less or so with Omicron. And then again, this one cuts off our sidebar, so you have to find your way back.
Cameron?
Oh, yeah.
Excuse me, before you move on, you want to say something about the difference between the numbers of deaths reported on our current dashboard versus this dashboard, and
Right.
why it's different?
Okay, so yeah, our current dashboard is displaying 126 deaths, and here we have 119. You'll notice it says total confirmed. So this dashboard is going to report only confirmed deaths. And we have these 7 others on our old dashboard. Remember, there's 126 on there. My understanding is that there's 7 probable deaths, and those kind of date back all the way to the beginning of the pandemic, when it wasn't very clear how to define a death from COVID. And also there wasn't a lot of PCR tests, the most accurate test available. So those were labeled probable deaths, and we've kept them on our old dashboard, but this new one's only going to have those confirmed ones. So that's the difference there.
Right. We've spent a lot of time trying to reconcile between the state and our data. We've kept our data up to date very, very well within the state, but there are differences in how the collection happened. And at different times, the definition of a confirmed COVID death changed to only include PCRs. And we didn't think that it was reasonable at that time to change that on our dashboard, because even though they're not confirmed from the state's sense, they were very surely COVID-caused deaths when we counted them. So they'll be in the future, they'll be on probable deaths.
Thank you for elaborating there. That was great. All right, so we've done these top 3, and then finally we have some more details about the total cases and COVID deaths we've seen. So this one's looking at case numbers, this time broken up by age group. And it can be useful over here to compare it to the population, like the percentage of the population. So for example, 18 to 34-year-olds, the sort of young adults, make up about 20% of Mendocino's population, but they've had 31% of the cases. So there's a difference there. And then likewise, older than 65 make up about 23% of Mendocino's population, but they've only had 11% of the cases. So we see some differences based on age.
And the other thing, if I can interrupt again,
Oh
is
yeah,
that remember the 18 to 49 years old in the county are not as well vaccinated as those who are older, and so they've suffered proportionately more illness and death as well. Although the older patients, I think you'll see on the next screen, have suffered more deaths because they're just more vulnerable.
Yep, I think we'll get to those, that more detailed death data, just a couple more tables down.
Good, thanks.
So this one breaks up cases by the area of the county. And again, you can see there's some disproportionate case numbers. The Ukiah area is about 43% of county population, and there's been about 63% of the cases there. Whereas you look at the North Coast, that's about 18% of the population, but only 9% of the cases. So you can kind of see where cases have been clustering. And if you really want the breakdown, here's all the zip codes and the fine print that make up each region. And then finally for cases, this one's looking at race and ethnicity breakdowns. And again, useful to compare with the percent of county population. And then again, we're seeing some differences, not what you'd expect. For example, white residents are about 65% of the population. I've had about 50% of the cases, whereas Native American and Alaskan Native residents are about 4% of the population and 8% of cases, so doubled that. So this can be another useful way to look at what's been happening with COVID. And again, here's our confirmed death numbers at 119. And then I think here's what Dr. Coren may have been referencing earlier, looking at deaths broken down by age group. And I think we've understood for a while now that COVID unfortunately affects our older neighbors and residents much more. And we see that here in Mendocino County too, where 51% of the deaths are over 75. So kind of, again, a gradient through the ages there. And then same thing, broken down by race ethnicity. And again, you can see some differences based on the percent of the population and then actually the percent of deaths. So that finishes this page, and that's kind of going to be the four main categories of this new dashboard: vaccine coverage, hospitalizations, looking at overall cases and deaths, and then all these more detailed tables here for those that really want to dive in. So again, this page will be updated with all this new data, and this old COVID dashboard will be gone on Monday. So I think we'll open it up to questions now. But Dr. Coren, do you have anything else to say?
Well, I just wanted to remind everybody that now we have a break from COVID, but we don't know how long it'll last. So we're all now more able to make decisions for ourselves and our loved ones. And public health will continue to maintain the situational awareness of the county and also issue evidence-based advice to the community. So as we go forward, we are also shaping public health to effectively address the disparities, which I will be reviewing in future media days. And you can see on the dashboard how it comes out when you look at the finer detail in the data that has been requested for a long time. So thank you, Cameron, for going over that so well. And yes, any questions, we'll be happy to try and answer.
Okay, so for the structure for the question and answer session, we just have a couple members of the media and community with us today. So we'll go through in rounds, and each person can ask a question and a follow-up if necessary. We'll do one question for each round so we can just kind of cycle through. And then we'll also incorporate questions from the media, or excuse me, from the public, from YouTube and Facebook as well. So let's begin with Mendocino Voice.
Hi, thanks for going through all those different web pages. I want to start with a question for Dr. Coren about the drop in current testing levels. And I was hoping you could maybe just elaborate about whether or not you expect there to be any changes in testing availability via OptumServe or anywhere else. If you expect any testing requirements to continue, sort of what you see as the next stage of testing available locally here.
Yeah, well, our testing has decreased, and OptumServe is a company that needs to maintain some efficiency for paying their personnel. So they have decreased the amount of time that we get. We are maintaining our testing in the site at the fairgrounds here. And we are also maintaining our testing in the mobile, or it's now changing from a mobile van to a traveling team. There were sometimes only 1 or 2 or 3 cases in an afternoon or a whole day in some of the areas. And where those areas have other access, for example, a clinic that can absorb the requirement, we have cut back the travel team. It used to be the minibus, but it's a travel team in some of those areas. I think it's Anderson Valley and Point Arena and Mendocino, the city of Mendocino. We were cutting back, is very close, but I think we may be trying to add that and continue that service. We're trying to see what the demand is for that. That was somewhere in the range of 2.5 cases came in on average per day for the last month or so. So yes, there's been some cutback, but certainly we have a lot more capacity than our community is taking advantage of. The nice thing is that OptumServe is adding the rapid testing there. So people who need rapid testing can get them at the OptumServe sites or traveling team. And so that should very much help. And if they need PCR tests for special, work requirements, that can be done through those sites as well.
If I could actually just ask a quick follow-up to that. My understanding is that BA2 might be more readily detected with a PCR test than those rapid tests. And I don't know if that's correct, but maybe if you could just talk about how our testing availability might impact the county's ability to detect any rise in new strains or overall community spread moving forward.
Great question. So let me clarify a couple of things with the BA2 strain versus the BA1, the original Omicron strain, because it has been very confusing. We have always identified variants by genetic whole genome sequencing, which requires a test, usually, the nose swab, and then it gets interpreted at the lab. And based on certain criteria, the labs have been sending those specimens for whole genome sequencing. That means that the specimen goes, in our case, to usually the Valencia branch lab, sometimes Solano lab, and they put it through a machine that's actually very slow. It takes about a full day to run the tests. And they run a batch of tests, but it's still much slower than just a PCR test, and we get results. The interesting thing about Omicron was this S gene dropout. So they were able to do what that means. There are 3 different genes that they're looking for to identify the actual genome of these variants. And one of those 3 genes is the S gene. And it turns out that without a full or a whole genome sequence testing, labs were able to identify the Omicron variant because it had two of those three genes and was missing the third. And so it became a quickie way to say, oh, this is Omicron. It's no longer, it's not Delta. The BA2 variant has that S gene at this point. So the quickie way that wasn't whole genome sequencing to identify BA1, the original Omicron, is no longer effective. But if you're putting a sample through the whole genome sequence, you're going to tell whether it's Omicron 1 or any of its variants, including BA2 or Delta or any of the others. For sure, there could be variants that come along that make it more confusing, but that's not the case at this point. So many people have misunderstood this S gene dropout, but putting these tests through the sequencing is just simpler to identify them with the Omicron 1 than it will be with Omicron BA2. But BA2 is the same as all of the other variants in terms of identifying and understanding their whole genome sequencing. So the fact that we're changing our availability of sites, but we have a huge amount of capacity still left for testing, will not affect our ability to be aware of what variants are coming into our community. In addition, the state is incorporating wastewater surveillance that will involve whole genome sequencing of the viral particles that they recover from wastewater. And we have not gotten that yet in our county. It is something that we're looking into at this point. But for example, Humboldt County and Lake County do have that facility going on, and many of the larger counties have wastewater surveillance going on. And those are going to be very good ways to tell before individual testing that there's something in the water system, and actually test which variant it is. So that'll give us a very good way to maintain our situational awareness of variants. Does that answer your question?
Yes, it does. Thank you.
Okay, it was probably more than you wanted to know.
No, well, I mean, I'm now curious about when and how we might get the wastewater testing, because that sounds helpful, but I'll let other people ask questions.
Okay.
So.
And Tracy, I just wanted to check in. I don't think we've had you on our call before. Did you have a question? Any questions for Dr. Coren? Okay. If you do, just jump in. Looks like maybe not. We have a couple questions from Facebook, so let me pull those up. All right, first question, Dr. Coren. Is a second booster really effective for Omicron?
Yes, the first booster is effective. We knew that at the time that the first boosters were authorized, that immunity from the primary series was waning, and that was toward the end of the Delta surge, and we certainly saw it during the Omicron surge. And we understand that vaccine efficacy wanes after a certain number of months, it could be years. We had to find that out with all of the other, for example, childhood vaccines that we know now need as many as 4 or 5 doses before the children reach school in order to be effective. And we don't know that yet because we haven't had enough time to see how the population or how the vaccine works in the population for COVID. So the first booster definitely helped people with to fight against Omicron. Remember that even the 2 primary series has been very, very effective against severe illness, hospitalization, intubation with, in the intensive care unit, and death. It's been very, very effective. But what tended to wane first was the protection against mild to moderate disease. And the boosters help, and they helped our immune globulins as they were measured in the blood. And we believe that they also helped keep the terrible infectiousness of Omicron to a minimum for those people who did get boosted. However, it's been many months since that those boosters were given out, And we're now seeing in the population that there's a waning of the immunity of people who've had a booster. And again, the protection from hospitalization, intensive care, severe illness, and death is very high among people, especially who've had 2 vaccines and a booster. But we want to make sure people are very well protected, especially in the most vulnerable groups. So that's why they've said those people over 50 and those people with immune compromised conditions. And the other group that they've added are people who have had the Johnson & Johnson or the Janssen vaccine for both the primary vaccination and their boosters. All of those 3 groups, it's recommended that they consider getting a booster. The second booster does bring the immune globulins up to a very protective level, and so it should help.
Thank you, Dr. Coren. And for reporter questions, it looks like it might just be you, Mendocino Voice. So go ahead and jump right in.
Okay, I do have another question. So for people that are uninsured, you mentioned that California Department of Public Health would be planning to fill those gaps in federal funding, but that people should seek out a way to get registered. And I don't know how many details you have on that, or if you could just explain how that might change the process if people do need to go get COVID-related care or tests or vaccines.
So if they need COVID-related care, vaccines, testing, up until now, the federal government has been paying for all of it. But the Department of Health Services, California Department of Public Health, has always been around to back that up for people who were not eligible for HRSA funds. But they're extending that to anybody in California if they're registered. So people will need to be registered if they're going to get care, and any place that accepts, for example, Medi-Cal would be able to register them for the DHCS coverage. And so that's all I would say is go to your clinic. If your physician also accepts Medi-Cal, they would definitely have the eligibility workers in the apparatus to sign up.
And so just to clarify, do you know if that would change what people need to do in terms of, say, the OptumServe testing or getting a vaccine?
OptumServe at this point is not giving vaccines. That may change, and I don't know how that would affect it. As far as OptumServe, they should be eligible for those services, but they would need to be registered through a clinic OptumServe can get reimbursed through the state.
Okay, and that's likely they probably can't do that at OptumServe, but it's something
No, I
they
don't
could
think
do in advance of going to get a test.
that's my understanding. Yes.
Okay.
So, for example, if someone goes to a clinic or they go to the emergency room, there are eligibility workers that sign them up for whatever they need to be signed up for. And if they're not signed up for anything, they get signed up for Medi-Cal. If they have private insurance, then that will pay for it.
Totally. But if people have Medi-Cal right now, or they are uninsured and they go get a test, they might potentially get a bill for said test at this point if they're not registered in advance.
They should not get a bill if they're on Medi-Cal because that's a registration with the state.
Okay, so the Medi-Cal should just cover it regardless. Okay.
Yeah.
Sorry to get into the details.
No,
of
that's
that.
okay. That's my understanding, and I'm not an eligibility person either, but I think it's important for the public to know.
Yeah, thanks. I don't know if we're going to do.
Let's see, I'll get a question from Facebook just to keep in that rhythm, but then, yeah, we can take any more questions you have. Let me just pull it up here. Oh yeah, so now that there's a second booster approved, what does it mean to be fully vaccinated?
That's another good question. What I've heard from the California Department of Public Health is that the definitions of boosted is not going to change. Fully vaccinated, of course, is completing the primary series, and 2 weeks after that, a person is fully vaccinated. But boosted would be either 1 or 2 boosters. I don't think they're changing rules around that. For example, those orders that mentioned vaccinated or tested. Those people who are, if they're required to be boosted, then it would be 1 or 2 boosters, at least at this point.
Okay, we had a follow-up question too on Facebook about that second booster. And is that under an emergency use authorization? They've asked.
Yes, that is an emergency use authorization. We usually see these medicines and want to see them in the public for some period of time before they are given a full authorization. When it is authorized in emergency use, it is done with certain agreements between FDA and the companies that produce these vaccinations or other medicines, that over the course of the next period of time, you will do certain research on outcomes as well as side effects and produce that data to us. And that takes some time to develop that data. So then after a while, then a full authorization can be granted.
Excellent. And Mendocino Voice, I think it's back to you if you have any further questions.
I do actually. I have a unrelated question, but I was wondering if I could ask a follow-up question about booster shots, just to follow up on that. I'm assuming that, Dr. Coren, you would anticipate the 4th booster shot as being something that would sooner or later be approved for people under 50, or is the way people should understand that if they had received the first, they should be anticipating at some point needing to go get the second booster if they're not in the group that it's approved for right now?
That's a good question. So, they approve these based on evidence. And the evidence is, how much has the immunity waned and how susceptible is the population. And so they allow or authorize the use in certain populations. And that's why they're saying 50 and over. Other people have been able to get boosters who are younger without any other immune compromising conditions. But at this point, the FDA has authorized it for anyone over 50, and also people who are over 12 or 18 for the appropriate vaccination if they have immune compromising conditions, and those are outlined as well. So it may, but I think we're going to have to see the data that shows that the rest of the population needs it. It may be that people over 50 need it because there's more waning of the efficacy of the vaccine. And I'll just use as an example, it's not the only thing, but we look at the amount of immune globulins, gamma globulin, and they can measure that in the blood, and they do that regularly in various research. But they may also find that those under 50, even if they have a lower immune globulin, for example, they don't suffer anymore from an infection, and they don't have the same waning of immunity as those over 50. So I think we're going to have to wait. These are based on evidence, and the evidence is ongoing. The research is ongoing.
Okay, thanks for clarifying that. I think people sometimes, there's sometimes the question of just whether or not people should expect endless boosters into infinity or sort of, so I just wanted to ask about that piece.
Yeah, we hope not. We hope not. The influenza vaccine for influenzas are recommended every year still, and that is because the actual influenza variant changes each year, and there may also be some waning of immunity. So at the very least, we're hoping that we'll have a vaccine that will last a year. And hopefully it'll be more like, I'm hoping it'll be more like measles or tetanus. You get a shot, you don't need it in 10 years, or you don't need it again the rest of your life for measles. So we just have to see how this vaccine proves its efficacy. They're looking for vaccines that are not variant dependent. So most of the vaccines and treatments have been targeting chemicals on the spike protein that the virus uses to attach to the cell. But if they can get something that is a little more basic to all of these viruses and variants, then they'll have a more universal vaccine, and it may be more effective or less effective. We have to see what they work out. That's where research is useful.
Okay, thanks. My last question was sort of aside from where the testing van goes and these changes to the dashboard, if the county sort of and public health is planning to be ramping down other pieces of this, if you expect to be updating the dashboard as frequently, or what other changes might be coming in terms of the public health outreach and updates and resources given the current state of things.
So important is the current state of things. We want to keep our eyes open to new variants, any new outbreaks, and if that happens, then all these resources will be ramped up, and we'll have all these tools to see what's happening and where and when. At this point, the state is actually doing some rolling back of the frequency of its updates, and so that's why I think Cameron mentioned that our dashboard is expected to be updated twice a week, rather than on a continuous or ongoing way that we've done it in the county. So there are changes, but they will be dependent on the activity of this disease in our community.
Okay, thanks.
I'm not seeing any more questions from Facebook or YouTube. So I'll just, Mendocino Voice, was that the last question from your end?
I guess maybe just to clarify, so are you anticipating having this same meeting 2 weeks from now in terms of any additional questions coming up, or?
We anticipate having this meeting and continuing, relations with our press community. There are a lot of things that are going on now that COVID is not dominating our entire experience here in public health. We want to get back to the work of traditional public health, and also want to get back to addressing issues of the environment and disparities in our communities. And we're putting a lot of emphasis in that as we rebuild our public health activities. So yes, we do want to continue to have these meetings.
Okay, then that would be my last question. So thanks.
All right, thank you, Mendocino Voice. So on that note, Dr. Coren, did you have any more closing comments besides those?
No, I think, like I said, we're in a little lull. Hopefully it'll taper down and we'll be able to live with this virus in a new normal kind of environment. But we do have to keep our eyes open for changes. We can't be complacent. And so all the questions that were just being asked about surveillance and testing are things that we're paying a lot of attention to. But at the same time, we don't want to throw an awful lot of energy into those things while there are other things that we do need to pay attention to. So we are continuing, and we want the community to continue to be aware of what needs to be done, especially individuals doing their best to keep the illness at bay, especially from the most vulnerable people in our community. So masking still has a role, and if you're sick, stay home, get tested. And if there are questions, you can get reasonable answers from either your provider or give us a call at the call center 472-2759. Thank you very much.
Thanks, Dr. Coren. And so as mentioned earlier, we are going to have another media day in 2 weeks. That's April 15th on Friday at 2 p.m. And in the meantime, you can look at the website, which will have the new dashboard on Monday, or the Mendocino County Public Health Facebook page for updates as well. So thanks to everyone that listened and asked questions, and we will see you soon. Have a great weekend.
Bye all.